Dosimetry in radiopharmaceutical therapy. There are two speakers, and my name is Yuni Devaraja from University of Michigan, and my co-moderator is Dr. Carlos Jose Barrel from MGH. And the first presenter will be Dr. Chino Kandapat from MD Anderson.
Great. Good afternoon, everybody. Thank you for that kind introduction. And I know Rob put this session together, so thanks for the invitation to present here. Excited to speak here. So as the lecture, my title is Why Do We Dosimetry in Y90 Microspheres? I'm going to start by my disclosures in acknowledging that Y90 is really a multidisciplinary team. So I want to acknowledge my clinical partners in interventional radiology, nuclear medicine, and medical oncology. Also, I'd acknowledge my funding agencies, clinical trial patients, and trainees that have done a lot of hard work. So the loud tunnel lectures, I'm actually going to just set up and briefly introduce Y90, microsphere therapy, talk a little bit about the dosimetry, but the first three topics are going to be quick. My goal actually is to really spend time and really share with you what is the clinical trial update data out here, and really try to bridge what we have learned from Y90 into how we can use that when looking forward to RPT. So we know yttrium radioembolization or selective internal radiation therapy is the transarterial delivery of Y90-loaded microspheres. So these microspheres are around 30 to 50 microns in size. So after delivery, they get passively lodged within the tumor microvasculature because of arterial flow, right? We administer this through the arterial supply. Once these beta particles, once these microspheres with beta are trapped in there, their beta emission creates a radiation effect very close to the site of delivery, but it can spare tissue that is distal away. And we all know that normal liver is a pretty radiosensitive organ. So that makes it challenging for external beam treatments, for example. So this is one of the reasons why Y90 treatment has been successful in liver-directed therapies. So it is a multi-stage treatment. You have to do some baseline, you got to do some baseline imaging out here to make sure a patient is suitable for this therapy. And then we have to do a planning. Because when you do radioembolization, you do have organs of risk, right? You're looking at the lung to make sure there's radiation pneumonitis is being managed. You want to make sure the normal liver dosing is appropriate, so you're not causing any radiation-induced liver disease. And also, you want to make sure that you're not doing extrahepatic deposition, because focal uptake or focal deposition of Y90 into, let's say, the colon of the stomach can cause ulcerations and cause a lot of complications to the patient. And that is done. Basically, you bring the patient in, you plan, you do angiography, you map out the hepatic vasculature, you see where the flow goes, and then you basically deliver MAA that is loaded with technetium as a surrogate for Y90 particles, and you use the image distribution of that to plan your treatment, right? You, again, look at these three organs of, that I talked about, lung dose, tumor dose, and then you make your appropriate plan. Then you deliver the treatment, and typically you would confirm the delivery of the treatment by imaging with either a Y90 SPECT or PET after the treatment. And then clearly there's follow-up and monitoring of the patient since then. And I'm not going to speak a lot on dosimetry today. There is a dosimetry session at Tuesday from 10 to 11 in room 7B, so I encourage people to attend that for the details of the dosimetry. But let's capture Y90 decays with the beta captures 64-hour half-life. It does not have a photopeak emission. So when you talk of single photon emission, you're using the brimstone to actually capture the image. But it does have a 32 parts per million positive emission. So due to the fact that we administer large amounts of gigabecquerel activity into the patient, even though a small branching ratio of 32 parts per million, you can get good quality PET images after Y90 therapies. Right now, there are two devices in the market. One's called resin microspheres from Certex and glass microspheres from TheraSphere. They both have yttrium-90. The major differences are the carrier. Resin is a little bit less dense with 1.6 grams per cc, while glass is a little denser with about 3.3 grams per cc. The other difference being that the specific activity in these particles can be quite different, and the ranges are illustrated below there. We have to recognize that the absorbed dose is really proportional to the product, right, of the specific activity, okay, and the concentration. So concentration is spheres per ml, and specific activity means what is a becquerel per sphere, right? So then it's basically telling you becquerel per ml, which is concentration. So we have to recognize also that the clinical response that one sees may be impacted by this dose and coverage. So if you use different specific activities, the clinical outcome may be different. So pooling of this data just blindly or different specific activities should be done with caution. Similarly, we know there are device calibration differences between Sursphere and TheraSphere. So again, just blindly pooling that data needs to be done with caution so that we don't mix effects that we know exist between the devices. So let's bring about how do we actually do those calculations, right? And this is a session that leads from Y90 to RPT. So I thought I'll bring in the MERD formalism a little bit. So in MERD, we know the dose is the cumulative activity times the S factor. So cumulative activity, you got to understand, for Y90, it's a permanent implant. So we can do a very simple integration and determine what the cumulative activity is. Then we have to understand the S factor in terms of what is the dose. In Y90, we have no photon emission. It's all electron emission. So the dose that is being deposited is all local, and that is illustrated by this profile here. The profile that is shown here in yellow is the net dose deposited for a spot of activity that is sitting at 0. The blue is the beta dose, and the red is the photon dose. And you'll see there's a crossover occurring about 10, 11 millimeters. That crossover occurs at 6 orders of magnitude lower than the beta dose, right? So literally, the photon dose is a wash. We can just ignore it completely. So then if you take that equation, dose is A tilde S, when you do the math out there in terms of the S factor and the cumulative activity, you get this very straightforward algebraic equation. Dose is administered activity in the tissue times 50 divided the mass in kilograms. The other thing we note is in Y90 macrospheres, there's always an arterial venous shunting from the liver to the lung. Okay, so there is some fraction of activity that you deliver to the liver that can go to the lung. So you basically calculate this by knowing the lung shunt fraction, and you have to make an adjustment to what is the activity that goes in the liver, and you know that fraction goes to the lung. And in the standard dosimetry model, the assumption is that when you administer some activity, that activity is getting uniformly perfused within the liver. This is supposed to be a liver with sort of 2 tumors as a cartoon, okay? But the idea is it is just going to be, that is the model that's assumed, and the calculations are done. So clearly, there's no separation of activity between tumors and normal liver. Nonetheless, let's see what is the clinical outcomes of Y90. Y90 has been around for 25 years. So here's a paper that we put out at MD Anderson. We looked at our experience of 10 years of HCC patients we treated. So we looked at 180 plus patients, and we followed up and see what was their OS that these patients actually do. Just recognize that when you have HCC in your advanced disease, your median OS is about 11 months. Okay, so we looked at our population, and we saw, okay, we have 13.54 months. That doesn't seem like a major increase here. But when we started looking at what is our population, and you can see here, when you have low disease burden here, you do Y90, you have an OS of 22 months, right? It's almost a factor of 2 greater than what you would have if you didn't have Y90 and you just gave them standard care, which would be sorafenib. Then we've also looked at combination treatments where you give sorafenib plus Y90. So you can see in those cases where they have intermediate disease and it is aggressive that is needing sorafenib, the presence of Y90 does help, improve that from your standard, like I said, 11-month is the median OS. So this is clinical real-life data that shows the dosimetry schema that we are actually employing in Y90 is beneficial. And this similar corroborated data available with resin data as well, both for hepatocellular carcinoma and metastatic colorectal cancer, showing, decent OS benefits, and for colorectal cancer, again, PFS is the relevant factor here because there's lots of first, second, third line therapies here, definitely greater than 6 months. So these are positive studies out there that shows that Y90 is valuable in managing patients with disease. So we've been discussing about the uniform dose model here. So I'm giving an example here of, here is a realistic image of a liver, sort of with 2 tumors, okay? You have a large bulky tumor with low uptake, and a smaller posterior tumor with large uptake, and here's the sort of the SPECT image. So there's a couple of things you got to notice here. One is you have different tumors, you have different levels of uptake. Within a tumor itself, you have heterogeneous uptake. The normal liver has heterogeneous uptake. So clearly we know that this model is rather oversimplified, right? So there was a model proposed called partition model that recognizes, well, the tumors are going to have a level of uptake that is greater than the normal liver. So let's characterize that and capture that. It's called the partition model. And that model has been around since 1996. So it's not a new model per se. And then more recently, in the last 10 years or so, this concept of voxel dosimetry has evolved, where we're actually tracking what is the activity in an individual voxel and what is the dose on that. So let's see how these models actually manifest the calculation. So we can see here if I apply these models, as we expect, this model predicts uniform dose everywhere, so to a certain level. When you do partition, it separates that into a binary dose level, a higher dose of the tumor, a dose of normal liver, and note there is no differentiation of dose levels within this tumor. However, when you get to voxel dosimetry, now we are able to capture the actual distribution of doses within that, and we can recognize now, this tumor got a much higher dose than, for example, this large anterior tumor, and that there is a non-uniform distribution of dose in the normal liver. So the take-home lesson is if you have standard or partition model, we're really not able to assess the spatial heterogeneity of the dose distribution. And we know that the outcomes are based on spatial heterogeneity, right? You could have a mean dose that is very high, but if you got a margin that is not treated very well and cells are still viable, we know those are the cells that are going to actually proliferate and cause you a partial or incomplete response. So here's a clinical case that I've used to illustrate this point. So here is a MAA. This is a whole liver treatment. I've got a 440 ml tumor here. So it's big, bulky tumors here. We are not a liver transplant center, so we tend to see a late-stage disease at MD Anderson. This is the MAA. This is the Y90 image of this patient. And now let's see, if I apply those 3 different dosimetry models, how does it manifest itself? So for given the activity is about 5.5 GBq for this patient, we're getting about 120 gray if I assume the calculations are assuming that what is the average dose to the entire liver, right? If you did partition, it would say, well, it's not quite 108. It's 300 or so gray to the tumor and about 80 gray to the normal liver, right? So we can see now, because of the T to N, there is higher uptake, right, within the tumor, and that is being captured reflected out here. But you can see this. While it is higher here, it is lower here. We don't quite see that here, and that's where the voxel dosimetry comes in. Here now we can see, well, it's not actually 306. There are places with a lot more than 400 gray, right? If you look at the normal liver, sure, it says 80 here, but there are places with 50 gray here, right? So that's kind of what I was saying. You can see the true spatial heterogeneity when you start doing voxel dosimetry. So this is the same input. We're putting the same activity, same VOIs, same patient. But the doses reported can be different, right? So that is something we got to keep in mind. When you hear the word some dose, the first thing that comes, well, what model was it calculated that with, right? Because that does make a difference. The other nuance that kind of come into play is what are you using to make that dose calculation? Is it a planning, which is based on MAA, or is it a post-treatment verification dose where you know this is the actual dose delivered? So there are these nuances we got to keep in mind when you talk about dosimetry, especially for Y90, because a lot of these are curative treatments, and we really want to follow these patients. So there's lots of imaging, and I want to just demonstrate that if we do hard work, you can actually make these doses concordant, right? It's something that we have learned over the past 10 years to really pay attention to detail, and I'm just going to illustrate how this can be accomplished. So here's an example of a 4cm 8cc, segment 6 of a patient here. We treated this patient. We wanted to plan to give it 316 gray. We delivered 325 gray, and that was the baseline imaging. And then here is the MAA SPECT image, the Y90 SPECT and the Y90 PET for the same tumor. And those dose distributions are shown. That's zoomed up. It's the same dose scaling. So we can see that with the 3 modalities, let's say we look at spatial distribution, we are seeing very concordant dose distributions between those modalities, right, for the patient. And if we go a step further and we say, well, let's look at the DVHs for these patients, right? We can see now, we can get these DVHs to match up pretty well, right? So the point here is the old paradigm of, oh, MA is not predictable of Y90. You know, I think some of those arguments are getting less tenuous now, okay? Or becoming more tenuous now, is the other word. And then let's look what happened to the patient, right? Patient 3 months, 6 months, complete response, right? So if you give the dose to the right location, you can get excellent outcomes here. So let's go back to the question. That's kind of the state of where we are here, okay? So title of the talk was, why do we need dosimetry in Y90? And you're like, okay. So I've kind of talked about what dosimetry we do, where we are, and how these models affect us, okay? So historically, dosimetry in Y90 was based on safety, right? So, and it has an excellent safety profile. We are keeping patients safe and alive. But what we have learned is there's a lot of efficacy that has been demonstrated through real-world clinical experience, and I showed you a couple of examples of that. So now the idea is we want to migrate radioembolization from palliative to a curative treatment. And when you start thinking about in this line, then you really need high-quality imaging, right? Because you got to be precise in where you're delivering. You need higher radiation doses to actually have tumoricidal effect, and you need good targeting, so you're actually killing the cells you wish to kill, the neoplastic cells, and actually sparing normal healthy liver tissue. So the improved dosimetry techniques will help increase the therapeutic ratio, right? That is the working hypothesis, okay? So the idea is if you do a better job of targeting and planning, you'll do better outcomes. And I hope to prove that to you in the next 10 minutes or so. So let's look at where are we in terms of the clinical space related to Y90, okay? So I've shown you 3 color schemas here. So the black is what I'm going to discuss. The ones in gray I'm not going to discuss, but the black and gray are completed, matured studies that's already been reported out on. You've got 2 studies I'm going to discuss, the RAPID and the doorway, that the trial accrual is complete, but the data is not quite mature yet, but I'm going to give you an early peek at the data. And the Rowan and the Emerald 90s are combination studies that are accruing right now, and there is no data to report on that yet. So I just want to give you a sense as continuous work is ongoing in this space. So I want to start off with this trial called the Foxfire third flock study, and you'll see here, this recruited over 1,000 people, okay? It's probably one of the highest interventional trials ever done. This is the randomized clinical trial, phase 3, that is comparing first line for colorectal cancer. Should it be chemo alone or chemo plus Y90? Okay. Remember, resin was indicated for colorectal cancer and adjuvant therapy in 2002 in the US FDA. Well, unfortunately, this study was a negative study. There was no difference in OS because the primary endpoint was OS. Okay. They saw a delayed in progression in the hepatic arm, but that really didn't change the OS dial. So when we did a deep dive into this, one of the things we realized was they used a poor dosimetry model. They didn't really plan to give a certain dose to a certain tumor, so they didn't really get a response. And they had poor patient selection. A lot of these patients had extrahepatic disease. So if you're looking at OS and you're doing a local treatment, why would a local treatment really manage systemic disease, right? So those are some of the nuances we've got to keep in mind when you do a study. Then there was a SARA study. This is also a resin study that looked at first line again, HCC, right? So we're looking at sorafenib, which was a tyrosine kinase inhibitor that came out of the SHARP trial, against Y90, a head-to-head first-line treatment. And again, you see this. This was a negative study because they wanted to look at overall survival. And they saw there was no difference in overall survival between these 2 patient cohorts. These 2 studies came back to back about 2017, and the spirit in the community was pretty dull. They were like, wow, these therapies are, there's a lot of money that goes into doing these multi-center international trials. However, these, and they were corroborated by some other studies as well. However, they actually looked at a sub-study of this. For several patients, they had done a post-treatment imaging, and what they found was if the post-treatment imaging confirmed a greater than 100 gray to the tumor, then you actually was able to see in the Kaplan-Meier curve a difference between the OS, between 6 months and 14 months, okay? So if you actually delivered high dose, you got it. Then they also found, well, depends on where you deliver the dose, right? The good dose means that you deliver the dose to the tumor. That's where you want it to go, right? And the poor dose is you had the tumor, but the dose didn't really target the tumor. It's like you want to treat the right lung, but you treated the left lung, right? You don't really expect an outcome out of that, right? So if you look at now 100 gray and those that had good treatment, that means you treated where you should have treated, look at the difference. 7 months and 25 months difference in OS, right? So massive difference, right? Unfortunately, this was retrospectively done. They didn't prospectively design in the study. But this is one example that shows that if you give enough radiation and you give the right location, you can get good outcome in overall survival. We have other studies called Legacy and Razor. Again, these are using glass, okay? These are using small tumors, so typically 3 centimeters or less, something that would be ablated or undergo resection. So these are unresectable but ablatable lesions. What they have shown is if you give high levels of radiation, you can get CRs on these. And that is you look at the complete response rate, 84%, right? And look at 83%, so very high CR rates. And if you started looking and see how come they got these high CR rates, remember these are done with single compartment dosing. So if you actually look at what is the uptake and you do a really voxel level dose calculations, you realize that actually the mean tumor is well over 1,000 gray. The margin dose, right, was 860, and if you look at 2 millimeters beyond the margin, it still had 500 gray. So we're really covering all even that microscopic disease that is perhaps sitting outside the tumor. So it makes sense why they saw excellent results with this. And then we have the Dosisphere study that actually looked to see if I prospectively change my treatment schema from a single compartment 120 uniform to a partition model where I require the tumors get greater than 205 gray, okay, that is the experimental arm. What is difference? Well, you saw 71% response rate compared to 36%, and these were bulky tumors greater than 8 centimeters. And more importantly, you saw a 27-month OS versus a 10-month OS. Okay? So again, this is level 1 evidence that if you do dosimetry, right, you're able to see a benefit from dosimetry. This is the kind of studies we need to tell our clinicians and the regulators that dosimetry is valuable for medicine. So I want to give an example of also how we can look back at our data and gain benefit. So this is a study we did at Anderson. We looked at our own HCC patients retrospectively, and we derived the TCP curve for this. Okay? And we also looked at normal livers, and we figured out what is the normal liver dose level, what is the TCP curve dose level, and we designed a prospective study that increased the therapeutic ratio. We put a minimum dose to tumor that has to be achieved, so we kept that, and we put a max to the normal liver, right? So the whole idea is you cap normal liver, you put a min to you try to push that therapeutic ratio further out. We did follow-up imaging, and here are the results I want to show you on that. So after 3 months, this is HCC patients. These tumor patients have 3 centimeters to 15 centimeters is the size. So you're not talking about small tumors. And you can see at 3 months, we are seeing 100% disease control rate with 82% objective response rate, right? 55% CRs. So very good. We go down to 6 months, and you can see now the complete response rate has gone to 73%, and our objective response rate is 97%. We are getting excellent outcomes, right? Even at 6 months post-treatment. And you can see that responses on the waterfall plot. So this trial actually had the objective of 75%, and we beat that out of the park here with a 97% response rate. And what is really nice was all of these tumors between 3 and 6 months continue to show favorable response. It's not like anybody progressed back. Okay. I also want to point out that there is a study called DORE that happened. This is using resin for HCC. And you might be familiar, for those of you who use resin. Resin uses the body surface area way of administering activity. So it's not based on dosimetry. One of the key things about this trial was this was a partition dosimetry-based study. So it is a prospective study. It was a first-line treatment for HCC. So it was all treatment-naive patients. And again, we went through across the staging criteria here. And we finished. That study was actually led by my colleague and myself as PIs. And the interim analysis was done for 65 patients, and this is what we found. We found that, so we treated, tumors you can see out there from 0.3 to 8 centimeters. We used partition model. We had well over 500 gray delivered to the tumors in the interim analysis. And what we're finding is, look at the response rate, 98%. CR rates over 90%, right? So again, this goes to show, if you give the right amount of radiation to the right location, you can expect excellent outcomes, okay? So rest in peace, BSA, okay? The new package insert has, it will always keep BSA, but you have the partition model, so we can abandon that now. So the importance of dosimetry is not just within this room. Everybody recognized that. Even the manufacturers recognize that, and they have developed full consensus documents of how to actually use dosimetry within the clinical care paradigm. And there's such guidance documents put together by groups both for TheraSphere and SIRSphere, and I encourage you guys to read these papers. So I'm going to take the next few minutes here and try to bridge what are the lessons we have learned from Y90 into, as a segue to the next talk into where we're going with radiopharmaceutical therapy. So let's look at this timeline of it, right? So SIRT has been around 25 years, I said, right? The first indication where they got an HDE for HCC. It was an orphan disease. There was no other option, so that's how they got this indication. And then in 2002, we have the FDA approval for colorectal cancer. It was a long hiatus of, this is not to scale. And then in 2015, Quantum Spheres got the CE mark. And in 2021, the FDA gave TheraSphere approval for HCC. And in 2025, just this year, the FDA gave SIRSphere approval for HCC. And really, the driving factors for all of these progress has been dosimetry, right? You understand dosimetry, we understand dose response, and people are using it. So I thought through this a bit, and I said, okay, what does it take to go from palliation to disease control, right? We started reembolization in palliation. We are in disease control now. How did we get here? There were basically 3 different steps that was required out here. And that's a 25-year timeline. And let's look at this. And each of these boxes are 5 years apart, right? So you're seeing about 2000, 205. And what are these studies? The first level of study after a narrow indication is to say, you explore the data retrospectively, right? You look to see what is the dose response. Is there a dose response? That kind of thing. Once you have a dose response, then you're saying, what is the subset of a population that would benefit and try to look at efficacy that pulls out from your standard population that is better. So you need these 2A and 2B to look back retrospectively to figure out how do you do better dosimetry and who is going to improve from that. You need that signal first. Then you got to go and show that signal prospectively, right? You take that signal, and typically that is done typically in a small single center prospectively, and then that is very successful. You open that up and you do multi-center. So let's take a look where we are within the microsphere timeline. So you have TheraSphere and colorectal cancer that got approved in 2000. And then here's the physics things that are going on here, right? So you can see sort of in 2005, 2010, a lot of work was done, partition model. We did a lot of work on SPECT CT imaging, try to improve that. Later on, we got better at Y90 SPECT imaging. There was voxel dosimetry that kicked in about 2015. And there's a lot more understanding of SPECT and PET with Y90 in this current 5-10 years now. So if you look at TheraSphere, where is TheraSphere? The dose response studies of TheraSphere were happening, right? You got Cleveland Clinic, Etienne Garay, and we did our work, right? These all, based on these, there were single center studies that changed the dosimetry schema, right? They tried, this is our study called RAPID, that is the Dosisphere study, right? So they actually prospectively changed the dosage schema and demonstrated an improvement. And in 2021, FDA gave indication for TheraSphere for HCC, okay? Let's look at what's happening in SIRSphere. So again, there's a lot of work done to understand what is the dose response, what is going on. You've got Strigari, you've got Levelin, you've got HCC, you've got colorectal cancer. There's a negative study here. You've got the SARA study here. Nima from Emory did a HCC study that was a prospective, and then Doorway was a prospective study, right? That led to the indication for HCC. We are not sitting in isolation out here. We treat patients, and the patients that we treat change. It's a 25-year journey. What is happening? You got medical oncology, okay? So 2008, the SHARP trial came out, right? That's what introduced sorafenib, the TKI therapy into us, right? So it changed which patients we were treating. 2020, here comes the Atezo-Bev studies, right? There's the IMBRAVE, and then you've got the STRIDE regimen on the Himalaya study in 2022 that showed dramatic improvement for BCLCC patients. So the patients that are coming to get remobilization is changing because medical oncology is evolving. So as we think of radiopharmaceutical therapies, we have to kind of keep this in mind as well. So you can see when we started, this is the BCLC staging guideline here, from 0 all the way to D here. You know, we used to be up here, salvage treatments. Now, remobilization is sitting in BCLC B1, B2s, and all the way to BCLC A patients. We have completely taken over TACE. Okay? But that is due to prospective study that has demonstrated that. And we are in the NCCN, so we're also in the NCCN guidelines for colorectal cancer here, I'm just showing you. And so the parallels we can learn is, once they're approved, what we really need to do is to go back and collect our standard care data and start to look to see what are the patients that might benefit, what are the doses that are going to the organs, where is there an opportunity to tweak things further, right? And we got to, because this is a radiopharmaceutical, we got to look at more than just tumor control, right? You got to look at things like OS. You could even look at clinical response. Like if you're looking at PSMA, you could look at biochemical recurrence, right? You don't look at tumor response. And then once you have that, you choose which tumor profile and which patient population benefit. And then the goal is to do a single center. These tend to be non-randomized, but it is a way to show that the signal is real. You know, it could be a 10, 20 patient study. And then once those get mature, then you want to do a multi-center where you have then standardized the imaging, the dosimetry, response assessment to really flow that out. And even then, I just want to point out, there is no guarantee. Okay? You could have a positive prospective study, but that does not automatically mean FDA approval. Okay? Those require additional other steps. We can talk about that another time. So I just want to summarize here by saying, like, really, Y90 is a safe, effective treatment. It's really approved for the management of liver disease. It's critical to get the right radiation at the right level. And now it is in all the guidelines. And what is the catalyst? It has been dosimetry, right? We've actually used dosimetry to increase outcomes, better patient management, and excellent response profiles, right? So I really think that randomization is the archetype for a successful radiopharmaceutical therapy journey, you know, and I really want to point out that it takes time, so we need to be patient. You know, it takes time to do some of these things. And what we really need are clinical trials that are prospective with new guided dosimetry to push RPT forward out here. And with that, I want to thank you for your attention.
Thank you very much. We have time for a couple of questions.
Yep.
Yeah.
I want to make two comments. I used to work at FDA, and there was first off, you're dealing with a medical device which was approved by the Center for Devices, and the oncology products were reviewed by a separate office. And I forget the exact year, when Vigo, the alpha emitter, was approved. It was approved for the first time with overall survival as a metric.
Mm-hmm.
And the fact that it was an alpha emitter, it woke up some of the oncology, the non-radiation community. And prior to that, historically, it was palliation. So you're absolutely correct. But there's been a paradigm shift culturally among the different communities. So, and the dosimetry, it's tough because you have biodistribution. In this case, the liver is sort of an dead-end street. Everything collects there. But the other dosimetries, they uptake and they travel on.
Absolutely.
Very nice talk.
Thank you very much.
Anyone else? If not, I have a quick question,
Yeah.
comment for you, Chino. That was very convincing how you showed the value of doing dosimetry here, but my concern or question is regarding the correlation with between technetium MAA and the yttrium-90.
Mm-hmm.
Of course, for the very large tumor and especially in the dosisphere study, they were able to show good correlations, but often there are very small tumor where that correlation is pretty poor. So what happens in those cases? What would be the approach in those cases?
Right. So it's a great question. So it pointed out radioembolization is multidisciplinary. I can do all the dosimetry I want, but if it's not delivered in the right place, it's not going to give me the outcome. And who does that? That is our interventional radiology colleagues. So the technical skill of an IR is just as important when I do radioembolization in terms of dosimetry, because they have to actually deliver, right? So that nuance needs to be recognized. So let's think about that. We actually looked at I did a study in of patients about 2014, and I looked at MAA and Y90 and looked to see how often was the catheter in the right location. Because to start similar, if you want Y90 and MAA to be the same, a starting point is the catheter should be, naively thinking, should be the same location, right? At least you're delivering from the same place. What we found in our institution is it was within 1 centimeter only 50% of the time. So, because why? We didn't appreciate the fact that we really got to keep the catheter at the right location. Now, in our practice, we have changed that, right? We have the IRs recognize, oh, I really got to pay attention to catheter placement. What are the other things we recognize is flow diversions. In the past, we would have a bifurcation that was pretty proximal to where we delivered, and the flow would be diverted by laminar flow. Now, that knowledge is coming to the IR. So in the technical delivery, they're like, oh, if I'm too close to bifurcation, I need to move back. So your concern is spot on. Is MA the same as Y90? It is not. But we can do a lot more things, but that comes from a technical side to get Y90 to match MAA.
Yes, one more quick question.
What I'm trying to understand is, for an individual patient, what good is this dosimetry doing? Because you're not using it to plan how you're going to treat. You're just looking at how you have deposited.
Okay, so let me correct that.
radiation.
Right. So we do this prospectively, right? So those outcomes I'm showing you, we plan to give that, and when I say prospectively, that means we are a priori planning to give this dose to elucidate a response. And when we do that correctly, you are getting response rates 90%.
Has it changed, except for paying attention to where the catheter is?
And the level of dose
details.
that you give, right?
But has it changed the way the material is ordered? Are you ordering a different amount of radiation to put in, or are they just using the same amount
No,
that they've
you
always
change the
used,
prescription.
and then
No, you do
this is
change the
what we ended up
prescription.
giving them?
Correct. You do change the prescription. So if you we have looked at, if you do the same plan, BSA, partition, voxel, they prescribe different activities. So the actual activity, the vial that you inject, is different. So let me tell you this. My clinician, so let's take the story. If I have a minute, I'll tell you the story. So HCC, late stage, median OS is 11 months, okay? So if you're a BCLCC patient, now with the T-sub-F, it's higher. So that means when you typically get imaging, you have to wait 3 months to come for your first follow-up, right? So if you look at a patient, let's say they're 12 months, the first quarter of your remaining life, you don't know if this treatment worked, right? You come back, and then you know it. Well, my clinician, based on this, we do imaging, we do dosimetry the day of. He tells the patient before they leave, your tumor has got this amount of dose, you are going to respond. You go home and be rest assured. That sense of comfort that the patient recognizes is invaluable, okay?
That makes sense.
So we have seen real impact, actually, of these things in patient and in the way we deliver care.
Thanks.
Thank you for that question. Yeah.
Thank you very much.
So our next speaker is Dr. Hobbs. He will speak about why do we need dosimetry for RPT. He's coming from Johns Hopkins University.
All right, thank you so much. And thanks, Shinu. That was a really great talk. I learned lots of interesting things, many more details than I was aware of. So these are my disclosures. Do I have a button? Or am I clicking on something? Oh, yes, there. Okay, great. There we go. All right, I'm going to talk about why we want to do radiopharmaceutical therapy. And we had a great segue from the last talk. The idea is, hopefully, that we can use prospective dosimetry in order to better plan individual treatment, okay? And of course, it's a little bit more complicated in radiopharmaceutical therapy in the molecular sense than it has been in yttrium-90, but again, the outline has been given on how to make this work. I'm going to give an example of when this was done, actually, a long time ago, and then the other things that we want to do, and this also goes to the previous talk, is we build, a database of understanding why this is going to work using dosimetry for retrospective studies. When we do the retrospective studies, we understand what the relationships are, and from there, we can better plan. Okay? Dose reporting, and then that can lead also into combination therapies. So the current paradigm for radiopharmaceutical therapy is basically fixed activity, okay? And sometimes fractionation. So there's sometimes arguments between, whether this should be in nuclear medicine or in radiation oncology, whether we can share. But really, when you take a look at how we are treating patients, it's like a medical oncology drug, okay? It's everybody gets the same amount, and sometimes we fractionate. And what we want to do is to change that. So again, this is a chemotherapy type of approach. You give increasing amounts of activity when you bring a new drug onto the market, and when you start to see toxicity, you say that's the amount of activity that everybody can get. Okay? And then if you do fractionation, then you give a little bit at a time so that, the physicians, the treating physicians, can monitor the development of toxicities and say, oh, this patient looks like starting to see some toxicities, maybe we're going to pull back a little bit, or maybe even stop the treatment. Okay? So it's very qualitative. Whereas we know this is radiation, so that's where we should be doing better than that. Okay? Two things. Do I have a little pointer on the screen?
Oh, yeah, no.
Oh, there it is. Okay. We know how the damage is being done, both to the lesion and to the normal organs, right? It's absorbed dose. And absorbed dose to first order, and there will be a follow-up session where we're going to talk about how to do dosimetry. But basically, to first order is the area under the curve. It's the time-integrated activity. It's the activity as a function of time in the different organs or the different regions of interest, okay? And so a patient who has more uptake in the organ at risk and has a lower, longer clearance rate is going to have more absorbed dose, is going to be the one that sets the standard for everybody. Whereas a patient for the same amount of administered activity, which has less uptake in that same organ at risk and a faster clearance, would benefit from much more activity, okay? And the other thing we can do with radiation, of course, is we can image it, which we can't do with chemotherapy. And so we can get that data by either putting in a small amount of pre-therapeutic activity. So you can either give a small amount of the activity that you're going to give, or you can give a surrogate, like technetium-99m in the case of the yttrium 90 microspheres. Or if you're going to do a multi-fraction treatment anyway, you could use the first fraction of the treatment to measure as a function of time the activity in the different organs. Then you can say, aha, now I know what the individual patient's pharmacokinetics are. I know what dose the patient is going to get to each of the organs and the lesions as a function of administered activity, per unit of administered activity. And then I can calculate what's the maximum amount of activity I could give to each and every patient. Okay? Now this approach is known as AHARA, like ALARA, right? As high as reasonably achievable. That's, we're going to give the patient the maximum amount they could get based on their normal organ constraints. You can do, of course, it a little bit differently. There are, like if you have a low number of tumors and you know how much dose you need to get to the tumors, you can say, well, I don't need that much to give the tumor dose that I need. We could bring that down a little bit. There are, of course, other medical reasons. This is information you're going to be providing to the physician, but of course, there are medical imperatives sometimes, such as, you know, the patient has, you know, a faulty kidney or only one or something like that. Also, there may be radiation safety logistics. If you calculate that you can give 2 curies of activity to a patient, that might not be a good idea, right? Okay. But if you have a widespread number of tumors and the numbers are too extreme, it's not a bad first order approach. So the question is this all just a theoretical exercise, right? I mean, what is the variability from patient to patient? I mean, I've shown you a diagram, but what is the real world? And this example is the first example of actually dosimetry-based treatment planning. Now, it was very, very simplified. This was back in 2003 with Bexar, okay? And what happened was they said the toxicity is going to be driven by hematotoxicity, right? If we measure the whole body dose, it's a good surrogate, and we see that the threshold of 75 centigrade is a good threshold for bone marrow toxicity. And this graph shows the amount of activity given to different patients to get to that threshold. And you can see the variability from 50 to 150 millicuries under the bell curve, so that's a factor of 3 variability, and then there are some outliers going out to 5 or 6 times. So it's not just a small theoretical change, it's a huge variability from patient to patient. So if the people who are the most sensitive, like down here at 50 millicuries, are setting the standard for everybody, you know, look at how underdosed everybody is going to be. And this is not an exception. This is the more data we look at, we see for all the different radiopharmaceuticals, for all the different organs at risk, this is not atypical. Okay, so it's potentially a huge game changer. All right, so this was implemented actually, and Uni is getting very bored. She's seen this about 20 times. We did this back in 2008 with a pediatric thyroid cancer patient. She came in with metastatic differentiated papillary thyroid cancer, heavy lung involvement. That was the concern. So instead of giving a standard amount, they were like, well, you know, we might overdose the lung. So how do we know what to do? So we used I-124 and PET to image, and here you can see some of those images. This is at 24 hours, so you can see why there's concern. You can see a lesion here up in the brain, and you can see there's a large amount of lungs. So what if we give a standard amount and it's too much to the lungs? So we ran Monte Carlo, and again, stick around for the next session, which will go into more details on how to do the dosimetry. But basically, we ran dosimetry at each of the different 5 time points. We took the area into the curve, and we say, aha, we know what the dose is per unit of activity of I-131. And so if we scale that up to how much the lungs can tolerate to an MTD, this is how much the patient can tolerate. And it was about 60 or 70% more than what would have been given normally. We also ran a different method. So not only, and again, stick around to next time, there are different methods on how to do dosimetry. That first one I showed you was Monte Carlo based. This one is absorbed fraction based. People will go into details next time, but we used 2 different methods to make sure that we were getting the same result, okay? And the patient did incredibly well. Of course, it's a anecdotal case. The tumor's resorbed, the patient went home, and 20 years later she's doing, well, no, I guess not 20 years later, it's 17 years later, she's doing fine. So we can do this, and it's probably better. She definitely got more activity, so she certainly got more dose to the lesions, and yet it was safe. Okay. I do want to mention that although we're proposing, generally the idea is this would be a good thing to do in a lot of scenarios, like especially we're talking about lutetium, where these are the drugs that we're using right now, lutetium dotatate, lutetium PSMA. There's a good chance that prospective treatment planning would improve. For thyroid cases, it's not always obvious, and of course this needs to be proven for every RPT, but for most cases, when you're just looking at thyroid ablation or primary thyroid disease where there's a huge amount of uptake, you probably don't need to do dosimetry every single time. But maybe for metastatic. So that's also part of it. I mean, yes, we believe prospective treatment planning is probably a good thing, but we also need to make sure we know when to apply it properly. So then the question is, if this is going to be so good, and we've seen the results, so Ginu showed the Dosisoft results, right? When this prospective treatment planning, using the technetium-99m information to then plan how much activity to give to the patients of yttrium-90 microspheres, changed the overall survival from 10.6 to, what is it, 26.7 months. And we think maybe we could get the same thing in RPT. Why are we not doing this? Well, it's taken a while to convince people that dosimetry has a good, should be used. Drug companies for a long time have been very reticent. Now they're starting to enter into the conversation. Now that more drugs people are becoming more interested in RPT and there are more RPTs available, there is definitely momentum and inertia growing. One of the big factors that they're still saying is that the problem is now if we give, the same data to 10 different people, we're not necessarily going to get the same result. We're probably going to get a wide range. And SNMMI dosimetry challenge has shown that. So those are the things that we need to work on to standardize, get the right QA. There's also, a lot of people are interested in this, but dosimetry obviously requires a level of expertise greater than just simply administering the drug. And so we need a lot of retrospective education, we need a lot of prospective education to get nuclear medicine and radiation oncologists, physicists and physicians up to the point where they can do this well. There's also been a mantra for a long time that unless you have, a two-armed randomized trial, you haven't proven anything. And I like the way that Chinu showed that there's a lot of background work. It's not just simply binary, right? You have, if you do the retrospective studies, if you do the small single clinical trial studies, you can have good data that is pointing you in the right direction. And without having to say, well, you haven't proven the entire thing with the multi-center trial, therefore you have absolutely zero, which is kind of what we've been hearing for a long time. And so there is a lot of already good retrospective absorbed dose response relationships out there. I'm going to jump to the one on the bottom here where Dr. Devaraja here showed it. This is the graph. A good tumor absorbed dose response relationship for I-131 tositumumab, again that's Bexar, with a 13.6 month survival for patients whose lesions received greater than 200 centigrade as opposed to 1.9 for those patients who received less. There were a couple of reviews that have been published, one by Strigari in 2013 and one by Graves in 2020, where looking over all the publications, there's extensive evidence of correlations, right, between dose and response. So there's a lot of good things. Baudet famously established toxicity thresholds in yttrium-90 peptide receptor radiation therapy at 40 gray of BED for healthy kidneys. Maxon had an old, tumor response for iodine-131 for thyroid. So there are data out there. Another thing that is often brought up as to why we shouldn't be doing this is the inconvenience and cost. It requires spec machines and time on the machines and money for imaging to acquire the data to do the dosimetry. So who is going to pay for this? Machines are expensive. And then there's also often the concern, that it's inconvenient for the patients. But I mean, if we can prove that, patients are going to do so much better, which is likely, not completely proven, that you would think that we should be able to convince them that it's worth the inconvenience of coming to the clinic, especially when you compare not with nuclear medicine diagnostic, but with external beam therapy, for example, where patients have to come in every day for sometimes several weeks, 5 weeks sometimes. And then is it worth the cost? So this has also been part of the problem because the medical oncologists are often the people who are the ones who drive the clinical trials, who run the clinical trials. And we've managed to convince a large part of the nuclear medicine community now that this is potentially a good thing, but we still need to make inroads with the medical oncologists. Because what we need is we need people who really believe in this to try and sell this when they are doing those clinical trials, right? It's like this, not just, well, you could do this if you want to, but this could potentially really benefit you, okay? So if you can do better therapy, is it really more costly? If you're not going to get a patient back for 3 years instead of 1 year, in the long run, that's more cost effective. If you do better dosimetry instead of 6 fractions, you can treat in only 3 fractions and have a better outcome. You're going to reduce the number of fractions. You're going to reduce the time that the patient is going to, spend in the clinic over a 3-year or 5-year period. So I think there's definitely, a return on the investment. And if we can show that this is financially and clinically beneficial, then there will be motivation to buy more SPECT machines and pay for more physicists, and it should grow as a modality. Am I clicking here? It's not moving. I'm just going forward. Okay, I need to move around. Okay. The other reason to do dosimetry is because now that these are becoming more and more commonplace, a big area of concern in external beam is retreatment, right? The patient goes out, they're treated, they come back, and all of a sudden it's like, well, how much can we give to the normal organs if we've treated, a couple of years ago, 10 years ago? What's left that we can use on these normal organs? And it's going to be the same problem, people coming back from, they go first and they get their Pluvicto, and then they get treated with external beam. It's like, so how do I plan? How does that help me? I mean, as a planner, knowing that they've had 1,200 millicuries of Pluvicto doesn't really tell me what I need to be concerned about when I'm combining that with an external beam treatment plan. And another, if you bring those two together, close together, you can not just combine, but you can prospectively combine, say we can plan a combination, because maybe boosting one with the other is a way to go, and that's also becoming more commonplace. Then it's a similar problem. How do we combine those doses? So dose reporting is very important. So retrospective studies, so that you can tell your external beam colleagues or the dosimetrist, this is the dose to the different organs that you need to take into account when you're planning for the external beam plan. Okay. And what time is it? Do we have any time?
Still have time. 10
Okay,
minutes.
all right. I'm just going to give an example of the combination, one of the planned combinations that we've done. This was the first one. This was done about 10 or 15, 12 years ago with samarium, EDTMP, with external beam. So samarium EDTMP is a bone-seeking calcium mimetic. It was used to treat pediatric metastatic osteosarcoma. And the idea is that the toxicity should be more or less orthogonal. EBRT, is mostly toxic to the areas proximal to the lesion, whereas often RPT is just where there's the most uptake. And in this case, as you can see, not only can you see the lesion very well, but you can see, the skeleton. And so the concern was for to first order bone marrow. But what we did is we did autologous stem cell support. So we would take the stem cells out of the patient, treat them with both samarium and then external beam, and then after the radiation had died down, we would give them back their stem cells. And then that way we could treat to a much higher level. And so what we do in principle is that you use, since both of these therapies are radiation modalities, you need to use standardized dose. Because one of the tricks, and I encourage you to go to a talk tomorrow, there are some complications. And maybe I missed that. Did I miss that? Okay, there is one issue, maybe I'm going to mention it right now, that I elided. There is uncertainty in what the normal organ threshold and tumor dose thresholds are. And one of the things that we're struggling with now is not only the difficult and standardization of methods and results, but is also saying, well, how do those thresholds relate to external beam? Can we just take the external beam thresholds? Can we use standard bioeffect modeling to say, you know, we'll use the BED to say more or less what it is, and there are complications. So I would encourage you to go to the talk tomorrow on basic radiobiology to understand how we're trying to deal with those issues. We don't have time to go into that right now. But to first order, the idea is, in principle, you could do this. You could write out the BED, right, for both external beam and for radiopharmaceutical therapy, and then set them equal to each other so you could convert from one to the other, kind of like a Withers formula, but there's a little bit, you know, the G factor that you should be familiar with if you're an external beam from brachytherapy, right? It's the same G factor, the Leakage-Side factor. So you can convert your RPT dose to EQD2 or EQD0 or whatever you need to plan an external beam. And then in theory, if you have a dose map, you can then export into your treatment planning system and plan for a combined treatment plan, okay? There were some technical problems. It's not that I won't go over. The BED equivalent is, you have to be careful. As I'm saying, this kind of goes towards what I was saying about the normal organ thresholds. When you're going from one RPT to another, you're going from external beam to RPT. Especially if you're looking at self-dose, there can be non-equivalencies because the uptake in the normal organs, which drives the dose in the normal organs of radiopharmaceutical therapy, may not be uniform, okay? It may be driven by specific cell types, it often is. So if you're looking at self-dose in areas of high uptake, you need to be a little bit careful. If you're looking at cross-dose, though, this works pretty well, okay? So this is what we did. We collected stem cells for autologous stem cell support. We used a CT sim, so this is something that we learned if you use. So one of the issues earlier on in radiopharmaceutical therapy dosimetry was registering from one time point to another. And if you have people who are just lying in nuclear medicine couches like they used to for a diagnostic and often in different positions, the registration and getting good dosimetry registration was not very good. So we would use the CT sim fixation devices from EBRT for the RPT to get better. We were given a low dose of samarium, so we would do that pre-therapeutic to take a look at what the absorbed dose coefficients, so the absorbed dose per unit of activity in the normal tissues and the tumors were. And then we would scale, we would bring that into the external beam treatment plan and combine that as a beam with the other beams for external beams. Now, it didn't work well straight out of the box because, of course, the optimizer would just set the RPT dose to 0 and say, just put in 0 and, you know, I could do a better job with just all the external beams. So we had to manually set them at different, but we could go, like, for example, 5 millicuries per kilogram to 10 millicuries per kilogram to 15, and we would vary them and we would see when we combined that with the external beam, which would be the best plan. So this was an actual prospective, both RPT and external beam. And this is an example here. So you see here, this is a tumor that's, and the concern here is the spinal cord, which needs to get less than 50 gray combined. And here's the external beam plan. And what we did was we had, you know, almost 20 gray from RPT, 50 gray from EBRT, and kept the combined less than 50 gray of toxicity. So you can do this. It's becoming more and more popular. Sometimes yttrium-90 with external beam. There are definitely issues with yttrium-90 microspheres and external beam in terms of the equivalencies of dose that we haven't really figured out. So often those types of approaches are only semi-quantitative. Again, there are definitely issues when you're looking at self-dose for normal organ RPT dose, but it has been proven to be viable that you can give an amount of dose in lesions using this boost approach that you could not give with the single modalities. So that's, another reason to do this. Wow, I don't think I've ever given a talk that I got finished before I went. This is unusual. All right, so there are good reasons to do dosimetry. The holy grail is personalized dosimetry, trying to do for the radiopharmaceutical therapy what is being done for yttrium-90 microspheres. And yes, yttrium-90 microspheres are a very good archetype of how to get there. But things are much more complicated in radiopharmaceutical. There are just many more steps in the dosimetry. There is a much less standardization, and there's certainly much less harmonization in terms of results. So there needs to be a lot of work done in that regard before we can convince the drug companies and people in general that it's safe to plan based on surrogates or pre-therapeutic amounts for treating patients to their own personalized MTA. But it is within reach. There is, because we have been systematically underdosing, there isn't a lot of good retrospective data for normal organs, but we are accumulating decent retrospective data for lesions. We need to try to push that and get some more retrospective data for normal organs as well to fit into this. Yes, hopefully we will get there. Retrospective dosimetry is great practice, as well as validating, as well as being able to then to report and say, put in the patient record, these are the doses that the patient got to these different organs, so that if they go back for radiation, they can get more. All right, I think I'm done. Thank you.
Thank you very much, Rob. So we have time for 2 questions.
Thanks for the lecture, Rob. So I think one of the things we should keep in mind is you have these drug companies that have an approval, right? 4 cycles, 6 cycles. If we are going to drug companies and saying, let's do a dosimetry study where instead of giving 4 cycles, I can give 3 cycles, it's better for the patient. What is the interest of the drug company for that, right? You're suddenly telling them, look, instead of them selling 4, you're selling 3. So part of, I think, a lesson we probably should learn is, it's not the drug companies. We should go to non-drug companies that, which is getting challenging now, to really go for those kinds of funding.
Right.
But that is a limitation.
But, well, except for the drug companies are the ones who give the drug. And for a long time, they wouldn't allow you to give more than the... And what we are allowed to do now, and there have been dose escalation trials, is that you are allowed to give more of the same amount of fraction. So you give more fractions than is typical. So instead of giving only 6 fractions, there are definitely trials out there where you can give 7, 8, 9 fractions.
And they are interested in that because they can. But that's just a nuance to keep in mind. Here's a science question for you. So when you do the combination of external beam with RPT, you have alphas and betas out there, right? Is the alphas and the betas the same?
I'm sorry.
The alpha beta values, the ratios for between you combine EBRT with RPT.
Right. So yes, yes. So
you
we
put the
believe.
equations, but is the alpha beta the same or different?
So there is definitely a high amount of uncertainty on the alpha beta ratio, and we already know this even in external beam. In external beam, often we just say, well, your normal organs are all 3, and your tumors are basically 10. We've done a little bit better, but certainly the level of uncertainty is pretty high. It should be the same. From RPT beta and photon RPT and from external beam. At least that's the principle that we're going with now. And maybe as if we start refining those calculations and narrowing the uncertainty on them, who knows, maybe we're able to find, need to fine tune those values. But for now, that is the assumption, yes.
Thank you.
So let me say though, so again, for a long time, and I did pick a little bit on drug companies, they were just protesting and saying, no, we don't want that, we don't want that, we don't want to listen, because the concern is if we start telling them, we're going to do dosimetry, then they're afraid they might lose some customers. Now they're starting to listen. Now they're starting, and the point that they've done enough dosimetry themselves that they've been able to say, we're not confident in the ability of the community to get consistent and reliable results, which is a very valid point. And so that is why this is something that we really need to work on. Okay, but at least we're talking the same language now. Okay.
So quick question, quick response, please, if you don't mind. No,
I'll
thank
be
you.
quick, all right? Radiopharmaceutical dosimetry has a lot higher level of uncertainty. We can't go into why. It is not as accurate on a consistent basis as external beam, all right?
Yes.
The drug companies think very differently, all right? When they go for an FDA approval, they have to specify everything. However, once it's approved under off-label practice of medicine, they can modify their doses, they can do all sorts of things. And that's a fine point. And the drug companies are aware of the uncertainty, and they will hedge to a lower limit. And I've known people who've been upset with that, but they don't want to go to a higher, because when you have the uncertainty exceeding that high level, you will probably have a higher death rate.
Right, but I mean, I think that even though the uncertainty is not the same, it's certainly a lot less than the theoretical amount that we could increase. If we can increase, patient amount of dose by 60 or 80%, even if the uncertainty is 20% instead of 5%, and you build that into planning, again, they are interested. They are willing to. They're cautious with good reason. They're very cautious, but at least in the last couple of years, they've started to listen and talk the same language that we have. Whereas for the previous decade, it was completely closed.
Yeah, it'll probably take at least another decade. But I remember 2 decades ago when these concepts were being thrown around.
Yep. Thank you.
Thank you very much. Have a great conference.